Moving on to respiratory system and chest, I'd like to begin with, I would like to teach you all how to read a normal radiograph, because I think it's extremely mandatory that as a practicing physician, whether you're studying for a post-graduation exam or not, you need to at least know what a frontal chest radiograph looks like, or you need to know a basic interpretation. So starting with this is a frontal radiograph of the chest. The first thing that you look for, the right side marker, the date, and the registration number of the patient. Nowadays, a lot of x-rays, they may have the registration number down here at the bottom, but it's immaterial. You need to look for these things, because that will tell you which side the lesion might be, what is the actual side of the patient, the right or the left. You might either have a right marker or you might have the left marker. So over here. So this is what you have, your right marker, like I've already pointed out. So next thing what we see is you divide the lungs into 3 zones, the upper, mid and the lower zone. The upper zone is defined by the anterior borders of the first 2 ribs from second rib upwards. The mid zone is between the second and the 4th rib, and the lower zone is below that. So if at all you're describing a lung lesion or you see a lung lesion, you can put it as either is it the upper zone, is it the mid zone, or is it the lower zone. Another thing is you trace this. This is your trachea bifurcating into the bronchi. So this is basically, you look at in case there's a massive pleural effusion or is there a large consolidation, you need to see whether there's a mediastinal shift to the right or the left side. And this line, your trachea, this will give you an indication which side the mediastinum has it shifted or not. Now we come to these, this area known as the hyla. The hyla of the lungs, they are basically they consist of your pulmonary arteries, pulmonary veins, and your lymphatics, because most of your lymph nodes or lymph nodes enlargement will be seen over here at the hyla. You might also see lymph nodes enlargement at the right paratracheal region and over here in the subcarinal region. So you need to keep a watch for these. These are the common sites of lymphadenopathy. Like I said over here, this is a paratracheal region, this is the subcarinal region, and these are your hyla over here. So any X-ray chest where you might find that there's hilar enlargement, you need to know that it's either due to the pulmonary vessels, or is it due to a lymph node enlargement. Obviously, another thing might be you might even have a CA lung, but then these are the more common causes of hilar enlargement. Another thing is over here that I've pointed out. This is your aortic knob or your aortic knuckle, and over here these are your borders of the heart. This is your right heart border, your inferior heart border, and this is your left heart border. So in case there is enlargement of the left atrium or the left ventricle, you'll be seeing a bulge in your left heart border. Enlargement of the right atrium, you'll be seeing a bulge in the right heart border, and so on. Another thing is how to calculate the cardiothoracic ratio. So you measure your distance A and you measure your distance B. So if you get A upon B is less than 0.5, that's your normal ratio. If it goes more than 0.5, it's abnormal, or it tells you that there's enlargement of the cardiac shadow. Like I said, this cardiac shadow might be enlargement either due to enlargement of the heart, or it might be due to pericardial effusion. And these 2 little areas that I've shown over here, this is basically your costophrenic angles or costophrenic recesses. You have to look whether there's any blunting or not, because blunting over here would indicate pleural effusion or pleural thickening, or maybe even a small neoplasm might do that, but most commonly it is an indicator of pleural effusion or pleural thickening. So when we do a CT chest, this is what the normal lung looks like. Things look much more clearer. This is a lung parenchyma. These are the vessels over here that I'm showing. This is your trachea, going bifurcating into the right and the left bronchus. This is a coronal section. This is your typical costophrenic angles which I had showed you. And again, this is your axial. Again, this is your appearance of the lung. These are your hyla over here, and that's about. So any increase in the lung opacity over here, as we will be seeing further, you will see it as you should be able to characterize much better using this HRCT. So let me just talk about a few general pointers over here. Now, what are the curly lines? Curly lines, basically they are thickened peripheral interlobular septa. Curly A lines are thickened deep septa. Basically, when there's increase in the vascular, when there's pulmonary edema, there is interstitial edema. When there's thickening of the interstitium, the fluid seeps between the interstitium. That's where you get thickening of the septa. So transverse diameter of the overall lobe arteries is generally 9 to 16 mm. And a free intraperitoneal air is more commonly seen on a lateral X-ray than a PA film. You need to know this. This is going to be a MCQ question. Free intraperitoneal air is more commonly seen on a lateral X-ray chest. Quantification of pleural effusion, this has to be done on an erect position. Obliteration of the posterior costophrenic angle. Posterior costophrenic angle is seen on a lateral X-ray chest. That's the most sensitive. So when there's 50 ml of fluid, that's where your obliteration takes place first. Obliteration of your lateral costophrenic angle, which is on your frontal projection, which I showed you. By then, there's at least 200 ml of fluid which has already accumulated. And if there's always a doubt, you can always do an ultrasound, which is extremely sensitive, when even your X-ray chest would be normal. So, quantification of pleural effusion, you must remember, preferably done in an erect position. Obliteration of the posterior costophrenic angle takes place first. Obliteration of the lateral costophrenic angle takes place later. Even if the chest is normal, and even if the chest X-ray is normal, and if you're clinically suspecting pleural effusion, go ahead and do an ultrasound. There's no need to do CT just to identify whether there's pleural effusion or not. So now we come to elevation of the domes of, what are the causes of elevation of domes of the diaphragm? Like what we said is over here, the left dome of diaphragm over here is elevated. So the causes would include either pulmonary collapse, is there a phrenic nerve palsy, is there intestinal distension, as in this case over here, there's distension of the intestine with an air fluid level. There's hepatomegaly or splenomegaly. These would be pushing the diaphragm upwards. Abdominal mass, this might include subphrenic abscess, tumors, hematoma, or a pancreatic pseudocyst, eventration of diaphragm, or scoliosis. Scoliosis would cause an apparent shift or elevation of the diaphragm. Pleural effusion, I've already talked about quantification of the pleural effusion, but the causes are multiple. So you can have an exudate as seen in pneumonia, you can have transudate pulmonary edema, cardiac failure, malignancy, which would have CA bronchus, metastasis or lymphoma, collagen vascular disorders, inflammatory processes of the abdomen, which is your pancreatitis, hepatic abscesses, drugs, post-operative changes. Now I need to talk to you about this phantom tumor. Basically, this tumor is a loculated effusion within the lung fissure, because you might see it on a particular day, but the next day if you take an X-ray again, that pleural effusion might have gone. So this is known as a phantom tumor. This again just shows that this on CT, this is how pleural effusion looks like. This is the pleura over here, and over here once again this is causing displacing the lung anteriorly. This all is your pleural effusion. What are the causes of opacification of a hemithorax? Once again, pleural effusion, consolidation, collapse, which is the lung collapse, your massive tumor, your fibrothorax, or even changes due to post-pneumonectomy status or your lung agenesis. Now, this was a patient with lymphoma. So, there's so much of mediastinal lymphadenopathy, and there is massive pleural effusion. So this has resulted in a massive opacification of the left hemithorax. Pneumothorax, the causes include spontaneous pneumothorax, which you might have it if there's a pre-existing bulla or a cyst, iatrogenic, traumatic, secondary to mediastinal emphysema, Secondary causes, again, emphysema, honeycomb lung, cystic fibrosis, pneumonia, bronchopleural fistula, meds, especially from osteosarcoma. Now we talk about asana opacification. What is the asinus? Asinus is a terminal unit of the airway. So over here, just as a diagrammatic representation, what I'm showing over here is this terminal air unit. It has air within it, so that's why it's appearing black. So over here, it's appearing black because it has air. But once over here, once it is filled with either exudative material or tumor cells or any mucopurulent material, it appears white and it is seen as a dense patch on the X-ray, or it might appear as an area of consolidation or a solitary pulmonary nodule in the lung on CT. So that once again, let me tell you, the causes are transudates, cardiogenic or non-cardiogenic pulmonary edema, exudates, hemorrhage, malignancies, aspiration. Asana opacification. Now this can, like I said, this can lead to formation of a nodule, a solitary pulmonary nodule, or even consolidation of the lung. Now over here, what we see is this is consolidation of the right lower lobe with a nice air bronchogram sign. So over here, this is due to a pneumonia, and this is a speculated solitary pulmonary nodule, which as a radiologist we need to differentiate: is it due to a malignant neoplasm, or is it a granuloma, or is it a hematoma? So there are different criteria for evaluation of this solitary pulmonary nodules. So what are the causes of a solitary pulmonary nodules? Again, a long list. You can have carcinoma, you can have granuloma, hematoma, metastasis, chronic pneumonia or an abscess, a hydatid hematoma, bronchocele, or even a pulmonary infarct. Now over here, now look at this solitary pulmonary nodule over here. It has lobulated margins, which is quite worrisome because the lobulated margins, they are quite often seen in neoplasms. Another thing is, if you see a solitary pulmonary nodule and you say, okay, fine, let it be, let's follow up, on the next, maybe after 2 months time, 3 months time. So if the lesion has grown, okay, by 26%, so then, they say that the doubling time of a carcinoma is 26% in 30 to 400 days. The next thing to do, in case if it's a suspicious lesion, you either do a biopsy or you do further evaluation. So let me tell you, this is a solitary pulmonary nodule that we have seen over here. Then we do a PET imaging like we talked about it before. So this is your solitary pulmonary nodule. And over here, once you fuse this and this image, what you get is a highly metabolic, what you get is a lesion showing extremely high metabolism. So this could be lung malignancy. So the next step would be taking a biopsy of this lesion and sending it. And this is commonly done using CT. Like we said, we talked about CT interventions. So the patient is made to lie down, and this is a lesion, and this is a needle tracking through the chest wall into the mass over here. Talking about cavities, now over here, cavities can be, the causes can be infective, like tuberculosis, neoplastic. You can have vascular, you have abnormal lung, which is cystic bronchiectasis, or cystic bronchiectasis, or any other lung cavities, the cause of which can be multiple, which include infective, neoplastic, vascular, abnormal lung, or even miscellaneous. So over here, as a radiologist, we try to identify the cavity. Is it thick-walled? Is it thin-walled? So over here, what I see is, this is a cavity over here. It's mildly thick-walled cavity. What are the contents of the cavity? Is there, fluid within it? Is there a mass within the cavity? And especially cavities due to tuberculosis, they are prone to develop something known as Rasmussen's aneurysms. You need to know this because they're quite common cause of hemoptysis in a patient with tuberculosis. And these aneurysms need the treatment of hemoptysis due to these aneurysms is bronchial artery embolization. Now, thickening of the cavity, the thickening of the walls of the cavity. If it is more than 4 mm thick, it is called a thick walled cavity. If the thickness of the wall is less than 4 mm, it's a thin walled cavity. Thick walled cavities are always suspicious for a malignancy. Hence, you need to view this with caution. Again, we go to miliary opacities. The list includes tuberculosis, histoplasmosis, metastasis, pneumoconiosis, which includes silicosis, cold workers, pneumonia, and hypersensitivity pneumonitis. So these over here you see in the CT, the cross-sectional, you see multiple nodular opacities which are known as miliary opacities over here. That's how it appears. Now, extremely important point, especially for physicians in our country, they need to know what are the radiological manifestations of tuberculosis. It can present as consolidation, miliary tuberculosis. It can either present as a solitary pulmonary nodule or like a tuberculoma. Cavitation, as we see over here, you can see a calcification or parenchymal scarring. These are the two signs of inactive or a healed infection. You can have mediastinal lymphadenopathy or you can have effusion. Now, consolidation, miliary tuberculosis, tuberculomas, cavitation, lymphadenopathy, and effusion. These are more likely to represent an active disease process. So over here, what we get is, a necrotic lymph node. It is in the right paratracheal region. Over here also right paratracheal and pretracheal region. These are your manifestations of tuberculosis. Then there are patterns of pneumonia, although this is not a rule, but vaguely, they have been classified. So the patterns of pneumonia, certain infections, they follow a certain pattern. But obviously this is not the rule, but it's good to know. So lobar distribution is generally seen in Streptococcus pneumonia. So this pneumonia predominantly is known to involve an entire lobe. So you should think of this. Bulging fissures seen in Klebsiella. Pulmonary edema, commonly seen in viral pneumonias and pneumocystis pneumonia. Pneumatoceles seen in Staphylococcus and Pneumocystis carinii pneumonia. Alveolar nodules are seen in varicella and tuberculosis. Mediastinal masses, now these would include your thymoma, teratoma, your thyroid, ectopic location of a thyroid or a retrosternal your lymphadenopathy, aneurysms, metastasis, neurogenic tumors, duplication cysts, or paravertebral abscesses. What I mean by duplication cysts are cysts arising from the esophagus, or the cysts arising from the trachea or the bronchus or even the lung cyst. So this is over here. This was one patient who had presented with a mediastinal mass. So this is what the X-ray showed, a large mass over here. And when we do a CT, what it showed us was, a large lobulated mass having calcium over here, this bright is calcium, and over here fat. So this mass would be, a teratoma or a dermoid. So that's how we try and characterize the mass. And cross-sectional imaging in chest. So when do you need further imaging of chest? Okay, you've seen an X-ray, you've picked up a lesion, you picked up the multiple lesions. So when do you need to do further imaging, or probably the CT? When there's mediastinal widening, when there's a solid lung lesion, parenchymal and interstitial diseases of lung, when you know that the patient already has a malignancy, you want to stage it. You want to see how far has it gone. Has it involved one lung, or has it involved the second lung, or has it involved the chest wall or not? Is it encasing any artery? So pyrexia of unknown origin, enlarged height, large shadows, suspected pleural or pericardial diseases, and suspected aneurysms. So what is HRCT? HRCT stands for higher resolution computed tomography. It's basically done to evaluate the lungs and not the entire thorax. Basically, it is 1 mm thin section taken at the highest resolution of the equipment with special sharp algorithm. It is a non-contrast study. It is a non-contiguous study. That means you take one slice, two slice, then there's a gap, then there's one slice, two slice, and there's a gap. So it's a non-contiguous study. And it is meant to detect and characterize diffuse pulmonary parenchymal pathologies. So let's talk about one of the more common lung diseases caused due to occupational lung disease, which is asbestosis. It might present as pleural plaques, diffuse thickening of the pleura, effusion. It might lead to mesothelioma, that is a tumor of the pleura, fibrosis, bronchogenic carcinoma, round pneumonia, or even a peritoneal mesothelioma. So over here, what we say we get is some fibrosis over here. These are these plaques over here, pleural plaques, thickening, calcification. And over here, this plain study over here, it helps us to pick up the calcified plaque. So this is pretty much asbestosis. Then talking about interstitial lung disease, or maybe the chronic obstructive pulmonary diseases. I would like to start with chronic obstructive pulmonary diseases. This is what you get. This is a smoker, where you get a centrilobular emphysema within the lung in a smoker. So over here it has upper lobe predominance. So if you see over here, this is the normal lung parenchyma, and over here if you see, there are these multiple areas of radiolucency. This is basically trapped air. So this is your emphysema over here, which is commonly seen in smokers. So once you pick up so once you see an X-ray, and if the X-ray is normal, and if you're still suspecting, then I think you need to go ahead for an HRCT. Once again, this is your paraseptal emphysema or your bulle. When your emphysema, paraseptal emphysema is seen predominantly again the subpleural lung parenchyma. So over here, as it enlarges, it turns into a bulle. Over here, right upper lobe, these are your bulle over here. This is your bulle over here, and the rest over here is your paraseptal emphysema. Now this bulle, they might rupture into the pleural cavity, and they may cause a spontaneous pneumothorax. And again, this is another pattern showing the entire lobe involved bilaterally. This is pretty much your panlobular emphysema. So over here and over here, the hyperinflated lungs are seen to cause narrowing of the heart. Again, hypersensitivity, pneumonitis. Over here, the X-ray findings may be non-specific, like mild or increase in the vasculature, or congestion in bilateral lower lobes. Sarcoidosis, you might have multiple nodules, centrilobular nodules, perilymphatic nodules, which might there. So, some of the nodules might also show the strian bud appearance, which is quite commonly seen in tuberculosis. So, if you see tree and bud appearance, you need to rule out, is it sarcoidosis or is it tuberculosis? One way to differentiate is the lymphadenopathy. You need to know that lymphadenopathy in sarcoidosis is non-necrotic, which can pretty much be which can be well identified on CT. So sarcoidosis is associated with lymphadenopathy, and one needs to look for those. Coming to the interstitial pneumonias, over here what you get is honeycombing of the lungs, you get fibrosis, you get traction bronchiectasis. So this patient that we're seeing over here has interstitial pneumonia, and this would be classified into the usual interstitial pneumonia or the idiopathic pulmonary fibrosis. There are multiple types of interstitial pneumonias, but you need to, at the current in the current stage, you just need to know about the idiopathic pulmonary fibrosis. So this brings us to an end to this session of respiratory system imaging of the respiratory system, and we have pretty much covered most of the stuff. And so you need to know your X-ray chest, your basic reading of your X-ray chest, causes of miliary opacities, causes of lung cavities, differential diagnosis for your solitary pulmonary nodules.